Okay. Okay, guys, welcome back. Now, in this today's class, let's discuss about the platelet disorders. Already in the previous classes, we have discussed about the RBC disorders. We have discussed about different types of anemias, macrocytic, megaloblastic anemias, microcytic anemias, and normocytic anemias with intravascular and extravascular hemolysis. We have completed. Now, in this video, let's discuss about the platelet disorders. Now, in the platelet disorders, let me begin with the first topic, that is hemostasis. Okay, hemostasis. So what exactly is hemostasis? Okay, hem means blood. Okay, hem means blood. The blood is getting stasis. What is this hemostasis? Hemostasis is nothing but the blood clotting. Okay, see, if there is a vessel injury, okay, if there is any damage to the vessel, do you think continuously blood is going to come out of the blood vessel? Okay, now let me take a blood vessel. Okay, I'm just going to take a small surgical knife or something. I'm just going to have a small cut. Okay, to a small blood vessel. Okay, so do you think continuously the blood will come out of the blood vessels and I will be drained out of all this blood? No, it does not going to happen. So in the next 5 to 10 minutes, definitely there's going to be a clot formation, and that clot formation is going to completely seal the leakage of the blood. Okay, why? To prevent the blood loss, to prevent me getting into the hypovolemia. Okay, so how this actually happens, how hemostasis actually happens. Okay, don't confuse with the homeostasis. Homeostasis is different. Okay, this is hemostasis. Now hemostasis, how it happens, sir? Okay, now for that, let me show you the blood vessel. Look at here. See, this is the blood vessel. First let me tell you what is the normal hemostasis. After that, I will explain you what are the disorders of hemostasis. See, these blood vessels, they are lined by cells. What are these cells which are lining the blood vessels? These cells are called as the endothelial cells. Okay, you know it, these are the endothelial cells. Now inside these endothelial cells, see, there are certain vesicles present. These vesicles are called as Von Willebrand's factor. Okay, these vesicles are called as the Weibel pellet bodies. They are called as Weibel pellet bodies. WP bodies, which are also called as the Weibel pellet bodies. Okay, you know it. Now question is, see, there is damage to this blood vessel. Okay, let me show you here. See, now there is a damage, sir. Okay, now here the endothelium is getting damaged. Now let me show you one more structure for better understanding. See here, this is the subendothelial collagen. See, this is the basement membrane. Endothelial cells are lying on the basement membrane, right? So this is the basement membrane, okay, which is made up of subendothelial collagen. Okay, so now this is the area of insult. That's the area of the damage. Some like damage to the blood vessel because of trauma or because of something. There is a damage. Now what happens, sir? See, what happens is this damaged endothelial cells. Okay, these damaged endothelial cells, they are going to release this Von Willebrand factor. Now, Von Willebrand's factor is released. Okay, now for the first time, Von Willebrand factor is released. Now, what this Von Willebrand factor is going to do is the Von Willebrand factor is now coming. Now, it is sitting where? It's sitting on the subendothelial collagen, damaged subendothelial collagen. Okay. Now, what happens is the first stage is going to start. What is the first stage? Primary hemostasis. Now, I am going to discuss about the primary hemostasis. So, what is primary hemostasis, sir? Okay, what is primary hemostasis? See, in primary hemostasis, mainly the platelets are the kings. Platelets are involved. Okay, mainly the platelets are involved. So, what these platelets are going to do is, sir, the platelets, whatever are there, see these platelets, whatever are there in the bloodstream. Okay, so these platelets are going to come and bind with the Von Willebrand factor. See, now a platelet is going to bind with the Von Willebrand's factor. Okay, how? Let me tell you. So these platelets, for example, imagine this is the platelet, a thrombocyte platelet. Now this platelet is having a receptor on its surface. Okay, there is a receptor on its surface. Okay, with the help of this receptor, it's going to bind with the Von Willebrand factor. This is Von Willebrand's factor. Okay, this process, the first process is called as platelet adhesion. Platelet adhesion. Okay, the name of this molecule, this blue color molecule, which is helping in the platelet adhesion, is called as GP1B. Okay, GP1B. With the help of this molecule called as the GP1B, there is platelet adhesion. Okay, done sir, platelet adhesion completed. Now, after platelet adhesion, once these platelets bind with the Von Willebrand factor, now these platelets are activated. Okay, now these platelets are activated. Now these platelets will release. Okay, now one fellow is activated. One of the fellow is activated. Now this fellow is going to call his friends. He is going to call his friends that there is their area of damage. There is area of damage to the blood vessel. Now you guys have to come and seal this area with the platelet plug. Okay, you have to form a platelet plug. That's the entire, like, you know, the aim of primary hemostasis is platelet plug formation. So what is this platelet plug formation? So platelet plug formation, it includes first platelet adhesion to the Von Willebrand factor. Adhesion completed. After adhesion, this activated platelets, now they are going to release certain substances. What are these substances? The most important thing is ADP. Now ADP is getting released by this platelet. Now this ADP is going to call the other platelets, and the remaining platelets, whatever are there in the blood, now they are coming and binding here. Okay, now many platelets will come and bind here, sir. So this area is going to get sealed. Okay, so I'm just showing you one platelet here, but millions and millions of platelets will come and try to clog that area. Okay, so what I'm trying to put into your mind is, once the platelets are activated, they release ADP. First, activated platelets release one thing which is called as ADP. The second most important factor which helps in calling the platelets is thromboxane A2. Thromboxane A2. So the same platelet, see in this platelet, okay, once after adhesion, now this platelet is activated. Now this platelet, okay, in this platelet, you know what happens? Now the membrane phospholipids, they are getting broken down, entering into the pathway of cyclooxygenase pathway. Okay, they are entering into cyclooxygenase pathway, and they are going to produce thromboxane A2. You know it, right? Yeah, like for example, okay, for those students who doesn't know, see, once this platelet is activated, okay, now imagine, so this is the platelet that is activated, sir, adhesion completed. Now in this platelet, see, cell membrane is there, right? Yes, sir. Is it made up of phospholipids? Yes. Now look what happens. Phospholipids, okay, the phospholipids are going to break down. Now in this platelet is going to break down its own phospholipids with the help of an enzyme called as phospholipase A2. Okay, phospholipase A2. Now these phospholipids are going to convert into arachidonic acid. Now this arachidonic acid in these platelets is going to enter into cyclooxygenase pathway. Okay, cyclooxygenase pathway. So after the cyclooxygenase pathway, now what you are going to have is prostaglandin H2, like, you know, prostaglandin G2, prostaglandin H2, things will be there. Now these prostaglandins, whenever they are entering into thromboxane synthase pathway, okay, now there is this prostaglandin, now it is entering into thromboxane synthase. Okay, so in this platelet this is happening. Now these prostaglandins are acted upon by this enzyme called as thromboxane synthase. Now thromboxane A2 is produced. Thromboxane A2 synthase, the enzyme is thromboxane A2 synthase. Now thromboxane A2 is produced. Now what this thromboxane A2 is doing? This thromboxane A2 is going to call the other platelets. Guys, all the guys, please come here. This is the area we have to seal. So all the platelets are coming and attaching with one another. For example, see this is the one platelet. It is binding with Von Willebrand's factor. Von Willebrand's factor. It's binding with the Von Willebrand factor. With the help of which molecule? GP1B. GP1B. Okay, with the help of GP1B, platelet adhesion completed. Now it is releasing what? ADP. Now once it is releasing ADP, multiple platelets are going to come. Okay, multiple platelets are going to come and bind with one another. Platelets are going to bind with one another. Okay, so this is one platelet. It's going to bind with this platelet, other platelet. Okay, so this molecule which I am showing here is called as GP2B3A. Okay, GP2B3A. Sir, with the GP2B3A, what exactly is happening? One platelet is going to bind with the other platelet. This is called as platelet aggregation. Okay, this process is called as platelet aggregation. So, how many things we have discussed? We have discussed about three important things. One is Von Willebrand factor. Von Willebrand factor is going to bind with GP1B, helps in platelet adhesion. GP2B3A is going to help in platelet aggregation. Which molecule is calling all the platelets for the platelet aggregation? Which cytokine is helping in the platelet aggregation? Thromboxane A2. Okay, thromboxane A2 or ADP, you can say. Okay, so platelet adhesion completed, platelet aggregation completed. So what happens at the end of the day is multiple platelets will bind with one another. Okay, going to form a platelet plug. Now this area is totally sealed with platelet plug here. Okay, there is a platelet plug, total sealed. Now what we have achieved? We have achieved the primary hemostasis. So primary hemostasis is completed, done. Now what we have to do? The secondary hemostasis. Okay, primary thing is completed. So secondary hemostasis. Question is, why secondary hemostasis, sir? We have completed, we have totally sealed, right? We have totally sealed. Now what is the point of secondary hemostasis? See, what you have, for example, let me put it this way. Imagine yourself building a house for you. Okay, you are building a house for yourself. You just try to build the house with just the bricks, sir. Okay, just the bricks, you are trying to build the home. Do you think it's going to be a stable home? No, it will collapse. Okay, without cement, it will collapse. In the same way, the platelets are binding with one another, but this is not a proper stable thing. It's not going to properly close the blood vessel. Okay, of course, it's trying to close, but it's not a stable thing. Okay, with the hemodynamic pressures, it can easily disrupt and it can go away. It can simply fall off. So what you need to do, you need to put cement over there. Okay, what is that cement? The clotting factors. So the clotting factors will come there and it will act like a cement, making this platelet plug stronger. So it's a stabilization. The secondary hemostasis main function is not the platelet plug formation. Platelet plug formation completed. Now secondary hemostasis is stabilizing the clot. Okay, stabilizing platelet plug. Is the stabilizing the platelet plug. How? By activating the clotting factors, by conversion of soluble fibrinogen. The soluble fibrinogen, whatever is there. Okay, soluble fibrinogen. See, in your blood, fibrinogen, the first clotting factor, the fibrinogen, whatever is there, that is soluble in nature. It's like just liquid. Okay, now the soluble fibrinogen should be converted into insoluble fibrin. Okay, insoluble fibrin. Now soluble fibrinogen is going to become insoluble fibrin. Now this insoluble fibrin is going to, this fibrin strands are going to act like a cement. They makes the platelet plug stronger. How this will happen, I will explain you. Okay, see, at the end of the day, what is the point of clotting? What is the purpose of clotting? Clotting helps in stabilizing the platelet plug. What exactly happens in the clotting? What is the aim of clotting? The aim of clotting is to convert soluble fibrinogen into insoluble fibrin. So this insoluble fibrin will stabilize the platelet plug. Okay, so how this happens, sir? With the help of clotting factors. Who is producing the clotting factors? See, liver is producing most of, okay, most of the clotting factors. How many clotting factors are there? So there are 12 clotting factors in total. Okay, there are 12 clotting factors in total. Out of the 12 clotting factors, one clotting factor is missing, sir. Who is that? Clotting factor number 6 missing. Okay, clotting factor number 6 is missing. Okay, if you check the number, there will be 13. Okay, there will be 13 clotting factors, but if you count them, there will be only 12 because 6 is missing. Sixth clotting factor is missing. Now, let's see how exactly clotting is going to happen, sir. Before that, I want you to know, see, in platelet aggregation, here I have shown you platelet aggregation with the help of GP2B3A. Okay, see, here I am showing you one molecule. This is the blue color molecule. The blue color molecule is nothing but fibrinogen. Okay, so that blue color molecule is called as a fibrinogen. So the fibrinogen is acting like a linker molecule. See, okay, imagine this is GP2B3A, this is GP2B3A. So in between this GP2B3A, now this fibrinogen is acting like fibrinogen only. Okay, fibrinogen is using as a linker molecule. Okay, just keep that point in mind. I forgot you to mention. Okay, so done. Now let me begin the secondary hemostasis. So who is the king in the secondary hemostasis? The king in the secondary hemostasis is the clotting factors. Okay, now what do we have here? Endothelial cells. Look. Here there is endothelial damage. Here is damaged endothelial cells. Here is the subendothelial collagen. As already mentioned, here there is a damage, right? Here this is the area of damage. Who is going to come first here? Let me show. This is a Von Willebrand factor. Von Willebrand factor. Many Von Willebrand factors will come. Okay, but here I am showing you only Von Willebrand's factor. Now this Von Willebrand factor, with the help of GP1B, it's going to bind with platelets. So this is platelet adhesion. The platelets are coming here and binding. For example, this is platelet adhesion completed. After platelet adhesion, what is happening? Platelet aggregation. With the help of which molecule? GP2B3A. Okay, platelet aggregation. Okay, completed, sir. So platelet plug is formed. Now what we need to do is clotting. Okay, clotting factors. Normally clotting factors are inactive in stage. They are always inactive stage. Inactive. Okay, whenever there is a need, wherever there is a need, there only clotting factors are going to be activated. Here, what happens is, see this subendothelial collagen. See, now for the first time the subendothelial collagen is exposed. Now the plasma, whatever is there. See, here is the plasma. Okay, now there is plasma here. Now in the plasma, who is there? Clotting factors are there. Okay, in the plasma, clotting factors are there, sir. Now those clotting factors are in inactive stage. Now for the first time, because of the damage to the endothelial cells, the subendothelial collagen is getting exposed to the plasma. The plasma is touching to the subendothelial collagen. So what happens, sir? Look, the first subendothelial collagen is exposed. So what happens is, let me tell you, first before going into the secondary hemostasis, let me write here 10 in the center. Sir, what is this 10? I will explain you. What is this 10? I will explain you later. Just write 10 in the center. Okay. So now tell me, how many clotting factors are there in total? There are 12 clotting factors. So write 12. Before 12, what is the number that comes? 11. Before the 11, which number will come? 10. Before 10, 9. Before 9, 8. Okay, completed. Before 8, there is 7. Okay, done. Sir, tell me, how much is 5 into 2 into 1? 5 2s are how much? 10, right? This is center, the 10. So 5 into 2 into 1. 5 2 1. So what exactly is this all numbers, if you ask me? Here I have shown the clotting cascade. Okay, in a simple way of representing the clotting cascade. I hope you already know about intrinsic pathway, extrinsic pathway, common pathway of coagulation cascade, which is mind-boggling, which is little intriguing. Okay, But here it's very easy, right? 10 in the center. Next, how many clotting factors? 12. 12, 11, 9, 8 one side, 7 on the other side, 5 into 2 into 1. Done. So what we have done here is, see guys, this subendothelial collagen, once it is exposed to the plasma. So in the plasma, who is there? In the plasma, there is clotting factor number 12, which is inactive. It's always inactive, sir. Now, once this clotting factor number 12, once it comes into touch with the subendothelial collagen activates clotting factor number 12. 12 is activated, done. Once 12 is activated, 12 activates 11, 11 activates 9, 9 activates 8. Means one clotting, it's a cascade. One clotting factor, once it is activated, it activates the other clotting factor. So 12, 11, 9, 8. Now 8 is going to activate 10. So this pathway which I have shown here, this is called as intrinsic pathway. Intrinsic pathway. Okay, intrinsic pathway. Now, once 10 is activated, 10 activates 5, 5 activates clotting factor number 2, 2 is going to activate 1. What is this 1, sir? 1 is the final thing. What is this 1? It is clotting factor number 2, that is thrombin. Okay, that is thrombin. So this thrombin is activated. Factor number 2 is activated means 5, see look here, 5 is going to convert prothrombin. Prothrombin is getting converted into thrombin. Once the thrombin is activated, thrombin is going to activate fibrinogen into fibrin. That's it. Fibrin came. Okay, clotting factor number 1 is activated, that is fibrinogen is getting converted into fibrin. Now what this fibrin will do? Fibrin will stabilize the clot. Fibrin is like, it's like strands. Okay, so it's going to completely stabilize the platelet plug. So the platelet plug is going to be totally now strong and stabilized. So here I have shown you the intrinsic pathway. So who is activating the intrinsic pathway? Subendothelial collagen. Okay, now what is the extrinsic pathway, sir? What is this 7? Extrinsic pathway is, see, whenever there is some damage to the tissue, okay, so blood vessel is damaged, okay, but surrounding tissue will also be damaged, right? The surrounding tissue, okay, whenever there is trauma, not only the blood vessel but surrounding tissue also little damaged. Now this damaged tissue, look, tissue is outside the blood vessel, so extrinsic. Okay, so damaged tissue. So this damaged tissue is going to release something called as tissue thromboplastin. This tissue thromboplastin is going to activate the factor number 7. It's coming from the tissue, sir. Okay, it's coming from the tissue. This tissue thromboplastin is nothing but clotting factor number 3. Okay, it's nothing but the clotting factor number 3. So this clotting factor number 3 is going to activate factor number 7. 3 is going to activate the 7. So once 7 is activated, 7 is going to activate 10. Once 10 is activated means 5, 2, 1. That's it. So this pathway which I am showing you here, this is extrinsic pathway. Okay, intrinsic pathway, extrinsic pathway completed. Now this pathway which is there in the center, that is 10, 5, 2, 1. This is the common pathway. Okay. Common pathway. So intrinsic factor completed, sorry, intrinsic pathway completed, extrinsic pathway completed, as well as the common pathway is also completed. Here the important points which you need to know for your exams is, say, for this clotting cascade to activate, you require certain things. For the activation of these clotting factors, you require certain important things, sir. What are they? See, 12 is activating 11. I am telling you, 12 activates 11, 11 activates 9, 9 to 8. Okay, done. But what is required? If you properly see, one clotting factor is missing, sir. See, how many are there total there? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Okay, who is missing? Okay, let me tell you, 6 is anyway not there. Okay, who is missing? Is factor number 4 is missing. Okay, see, factor number 4 is needed everywhere. Factor number 4 is nothing but the calcium. Okay, factor number 4 is nothing but the calcium. Okay, 10 are there, this is the 11th one. Okay, so factor number 4 is required for the activation of clotting factors. It's required everywhere. Okay, so fact 4 is done. Calcium. So right, for activation of clotting factors, what do you require is number 1 calcium. Second thing is phospholipids. See, these clotting factors, they are activated. Don't think they are activated throughout the blood. No, wherever there are platelets, see, only in this area the clotting factors are getting activated. Okay, only in this area the clotting factors are getting activated. So for the activation of clotting factors, what do you require is the phospholipid membrane of the platelets. Okay, only on the phospholipid membrane of the platelets these clotting factors are getting activated. Okay, so let me write here phospholipids of platelets. So these two are very important prerequisites for the clotting factors to get activated. Done. So how many pathways are there in total? There is intrinsic pathways or extrinsic pathway. Now this intrinsic pathway and extrinsic pathway, they are measured. Okay, the time taken for the intrinsic pathway, time taken for the common pathway. The time is measured. This study is called as, like, there are two studies which are called as PT and PTT. PT and PTT. Okay, PT and PTT are the studies. Let me write here PT and PTT. So PT measures which pathway, PTT measures which pathway. See, first of all, let me tell you which one is bigger. PTT, the name PTT is bigger, and which pathway is bigger, intrinsic or extrinsic? Intrinsic is bigger, see, so much, 12, 11, 9, 8. So PTT measures intrinsic pathway, PT measures extrinsic pathway. The time taken for PTT, time taken for intrinsic pathway and extrinsic pathway. Okay, done. Next. So some of the students will be having a doubt, sir, everything is okay. So 1, 2, 3, okay, 4 is there, 5, 6 is not there, 7, 8, 9, 10, okay, 11 is also there, 12 is there, but where is the 13th one? Okay, total here I am showing you 11. Okay, here I am showing you total 11. Okay, 11. See, for example, let me take a new color, for example, pink. Okay, see, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and this fourth one, total 11 are there. Okay, total 11 are there. But what we have discussed, there are 12 clotting factors. What is the 12th clotting factor? That thing, okay, that is nothing but, see, the final step is factor number 13. Okay, so let me put it here. Once you have fibrin, you need to cross-link the fibrin. Okay, you need to cross-link the fibrin and to stabilize the fibrin also. That is fibrin stabilizing factor. Okay, it cross-links the fibrin, so it makes the clot more stronger. Okay, it's a stabilizing factor, fibrin stabilizing factor. Okay, so clotting is completed, sir. Now, after discussing this, now let's begin with the pathologies. Okay, so disorders of primary hemostasis and disorders of secondary hemostasis. Primary hemostasis is just forming a platelet plug. Secondary hemostasis is just putting cement onto it, making it more stable. The cement is nothing but the clotting factors, activated clotting factors. Conversion of soluble fibrinogen into insoluble fibrin and fibrin stabilization, forming a strong clot. Okay, now the first thing which I want to put into your mind is, sir, if there is defect in platelets, tell me what's going to be affected? Primary hemostasis is affected or secondary hemostasis is affected? So primary hemostasis is affected. Okay, if there is a defect in clotting factors, if there is a defect in clotting factors, that the secondary hemostasis is going to be affected. Okay, secondary hemostasis is affected. Okay, so keep this point in mind. This is very, very important. Now first let's start our topic with the disorders of primary hemostasis. Okay. So disorders of primary hemostasis. Now, you know it already, primary hemostasis defect means there is some problem with the platelets. Okay, problem with platelets. So what kind of problems you can expect? Two types of problems can be possible. Okay, two types of problems. One is quantitative problem. Okay, one problem is quantitative type of problem. Means the quantity of platelets are not sufficient. There is thrombocytopenia. Okay, there is thrombocytopenia. So not enough platelets are there. That's causing the problem. So quantitative problem. Second type is qualitative. Okay, qualitative problem means the quality of the platelets is not good. So for example, quantitative problem is thrombocytopenia. Thrombocytopenia means less number of platelets. Okay, less platelets. Now, what's the qualitative problem? Means a defect in the platelets. Okay, defect in the platelets. So, having said that, now let's begin with the primary hemostasis disorders. First thing, quantitative problems. Okay, so let's begin. Yeah. So, quantitative problems. So, what are the conditions in which the platelets will go down? Okay, in which conditions you will have thrombocytopenia? Okay, first the condition that I am going to discuss is immune thrombocytic purpura. Okay, immune thrombocytopenic purpura. The first condition is immune thrombocytopenic purpura. So first let's justify this name. Okay, let's see what exactly this name is talking about. Immune thrombocytopenic purpura. See, immune here stands for it's an autoimmune condition. Okay, it's an autoimmune condition where the patient is producing, okay, IgG type of antibodies, where the patient is producing IgG type of antibodies. Against what? Against the platelets. Okay, these IgG antibodies are going to go and bind with what? Platelets. Okay, this is a platelet. So to these platelets, these IgG antibodies are getting coated. So because of this, okay, the platelets are going to be destroyed in the spleen. So such platelets which are coated, okay, such platelets which are coated with such antibodies, now in the spleen, okay, macrophages, okay, the splenic macrophages are going to totally destroy such platelets. First of all, say in the spleen, who is producing these antibodies? The plasma cells in the spleen. Is the plasma cells in the spleen is going to produce these IgG antibodies. Okay, the plasma cells in the spleen are going to produce these IgG antibodies. Once these IgG antibodies are coating the platelets, such platelets are going to be consumed by the splenic macrophages. So the splenic macrophages destroys platelets. So what happened to the number of platelets? The platelets are going to go down. So thrombocytopenia. Okay, thrombocytopenia. Okay, so the number of platelets are going to go down. When the number of platelets are going to go down, so no platelets, no platelet adhesion, no platelet aggregation. So defect in the platelet plug formation. Primary hemostasis is going to be affected. Okay. Now my question says, sir, this is seen in which persons? It's autoimmune conditions. Okay, most of the autoimmune conditions are seen in females, but this one is going to mainly seen in children, especially after the viral infection. So children after viral infection. Okay, after getting the viral infection, weeks after viral infection, a child can have this immune thrombocytopenic purpura. Now, still some students will have a doubt, what is this purpura, sir? Purpura is nothing but the bleeding. Okay, bleeding into the skin. On the skin, you can see the bleeding marks. See, petit K means small bleeding, small, pin, like, drop bleedings. That is called as a petit K. Purpura means little bit more in size. Okay, the size of the bleeding is little bit more in size. If you have big patches of bleeding, okay, if you have big patches of bleeding, then it is called as ecchymosis. So, petit K, purpura, ecchymosis, they are all the bleeding. Okay, based on the size, you can divide them into petit K, small, purpura little big, ecchymosis more big. Okay, there is also size, but that's not that important. So, PTK, purpura. Okay, ecchymosis. So, because of the immune destruction of the thrombocytes, immune system is destroying the thrombocytes. So, there is thrombocytopenia. So, immune thrombocytopenic purpura. The person is going to have the bleeding. Platelets are not there. When the platelets are not there, bleeding will happen even for a small damage. Okay, yes. For example, in us, if I have some trauma, okay, some damage, immediately there is going to be blood clot. Okay, small microvasculature, whatever are bleeding. For example, if I do like this, so some blood vessels which got damaged, they will be immediately sealed because of these platelets. Now, in the person who is having this immune thrombocytopenic purpura, such sealing is not going to happen. That will cause the bleeding into the skin. Okay, so that's why immune thrombocytopenic purpura. So, seen in children weeks after viral infection. This is a self-limiting condition, not a serious condition, self-limiting condition. Second, it's going to be seen in females, okay, especially females, okay, in childbearing age. Okay, seen in females of childbearing age. Okay, it can be secondary also. Okay, it can be seen in patients who are having SLE, that is systemic lupus erythematosus. So, you know, right, systemic SLE is also autoimmune condition where the person is going to produce multiple antibodies, different types of antibodies against the RBC, WBC, nucleus. Okay, anti-nuclear antibodies are going to be seen, anti-DNA antibodies are going to be seen. So, if the patient is having SLE, that those patients can also develop such kind of immune thrombocytopenic purpura. Okay, it's a self-limiting condition, not a big deal, sir. Now, what are the labs that are going to be seen? In the labs, okay, what you can see is, in the labs, there will be thrombocytopenia. Thrombocytopenia. Now, students will have a doubt. So, what exactly is this thrombocytopenia? Less platelets, okay, everyone knows it, less platelets, but how much less, sir? Usually, you will be having, how much? You will be having 3 to 4 lakh platelets will be there. Okay, so there will be 3 to 4 lakhs of platelets per microliter. Normal. But if you have less than 50,000, less than 50K platelets per microliter, then it is called as thrombocytopenia, means your platelet count is going down. Next, what happens to the bleeding time? Very important thing, bleeding time depends on the platelets. For how much time the patient is going to bleed? Bleeding time depends on the platelets, not the clotting factors. First, platelets, once they are activated, they will come and close. So, platelet plug formation done. Once the platelet plug is formed, bleeding stops. Okay. So, bleeding time somewhere between 2 to 7 minutes. Okay. Bleeding time is dependent on the platelets. So, in this condition, platelets are less. So, what happened to the bleeding time? For more time the patient will bleed. Bleeding time increases. Next, what about the clotting time? Okay, what about the clotting time? So, what exactly is this clotting time? Clotting time is dependent on the clotting factors. Clotting time is measured with PT and PTT. In this condition, there is no problem with the clotting factor. So, clotting time, that is PT and PTT, are normal. So, these are the laboratory changes. Bleeding time increases, there is thrombocytopenia, and the clotting time is going to be normal. Okay. Next, what else I want you to know is the treatment. Okay, you can know the clinical features. Clinical features are going to be bleeding, more and more bleeding into the skin. Okay, treatment. So who is the main culprit here? The main culprit here is the spleen, sir. Okay, the spleen is producing the antibodies. The plasma cells in the spleen are producing the antibodies unnecessarily, and it's the splenic macrophages who is destroying the platelets. Okay, splenic macrophages are destroying the platelets. So here the culprit is the spleen. So what we have to do here is splenectomy. Okay, splenectomy is the treatment that is done. Next, what else is, for these patients you can give IV IGs, intravenous immunoglobulins. IVIGs can also be given. If you inject immunoglobulins, this IVIGs, intravenous immunoglobulins, for like the reasons which exactly we don't know, but if you give immunoglobulins, the platelet destruction will come down. Okay. Now the splenic macrophages, see for example, the splenic macrophages are eating these platelets, they are continuously eating these platelets. If you give some other dish, for example, you are eating, okay, in a restaurant. Now, if the person gives a better dish, what you will do? You will just keep this aside and you will start to eat the other things. In the same way, the splenic macrophage is also causing the destruction of the platelets. Okay, they are destroying the platelets continuously. The moment you inject IVIGs, intravenous immunoglobulins, the splenic macrophages are better now, busy in removing the IVIGs. Okay, intravenous immunoglobulins will be totally getting broken down. So platelets are now spared. So intravenous immunoglobulins and splenectomy are the treatments that is done. So with this thrombocytopenic purpura is completed. Okay. Next, after this, okay, one condition I have discussed with you. What is that? See, in quantitative problems, thrombocytopenia, the first condition that I have discussed is the immune thrombocytopenic purpura. The second condition which I want you to know is MAHA. Okay, that is microangiopathic hemolytic anemia. Okay, yeah, microangiopathic hemolytic anemia. Okay, microangiopathic hemolytic anemia. In the name itself, it's there. See, microangiopathic. Micro means small blood vessels. Microangio means small blood vessels. There is some problem in the small blood vessels like capillaries. Because of that problem, there is hemolysis. Okay, because of that problem, there is hemolysis, and that hemolysis is going to cause the anemia. See, in RBC disorders also we have discussed microangiopathic hemolytic anemia is going to cause an intravascular hemolysis. Okay, so now here let me discuss what is that microangios and what is that pathology, why hemolysis is happening, okay, and how anemia is happening. Let me discuss one by one. See, in this microangiopathic hemolytic anemia, okay, let me write. It is seen in two conditions. Okay, there are two conditions which can lead to microangiopathic hemolytic anemia. Condition number one is called as thrombocytopenic purpura. Okay, thrombocytopenic purpura. Okay, see how this thrombocytopenic purpura is going to cause microangiopathic hemolytic anemia. Is, see, in this condition, thrombotic, in the name itself it's there. Okay, thrombotic means excessive thrombi are forming. Okay, that is leading to, see, thrombocytopenia. Unnecessarily thrombus is forming in the blood vessels. Unnecessarily thrombus is forming in the blood vessels. That is causing thrombocytopenia. That is causing purpura, bleeding. That is causing the bleeding. So let me put it this way. What exactly is this thrombocytopenic purpura? What exactly is happening, sir? See, this thrombocytopenic purpura is due to deficiency of an enzyme called as ADAM TS13. Okay, due to deficiency of ADAM TS13. What is this ADAM TS13 do is going to do? It's going to cleave what? Von Willebrand's factor. The Von Willebrand's factor is going to be cleaved. Okay, the Von Willebrand factor, it is going to be cleaved. into small particles, monomers. Once that function is done, von Willebrand factor function is done, you need to remove it. Okay. So when do we need a clot? Till the time the blood vessel is sealed, we need a clot. But after the once the blood vessel is sealed, you don't need that von Willebrand factor and all these things. Okay. So the von Willebrand factor need to be cleaved with the help of this Adam TS13. Now this is a deficient. Now once this is deficient, now what this von Willebrand factor is going to do? The von Willebrand factor is going to be continuously activated. It's continuously going to be there. Now this von Willebrand factor is going to cause what? Platelet adhesion. And that platelet adhesion is going to trigger platelet aggregation. Okay, it's going to trigger the platelet aggregation. So because of this, see, within a blood vessel, within the small blood vessels, okay, because of this, unnecessarily there is this platelet microthrombi. Platelet microthrombi are going to form, small, like this thrombi are going to form, platelet microthrombi. Because of Adam TS13 deficiency, the von Willebrand factor is continuously causing platelet adhesion followed by platelet aggregation. Small hills, they are just like a small hills. Okay, now during this process, unnecessarily, see, the platelet which was supposed to be freely circulating throughout the body, unnecessarily they are forming this thrombi. So what happened to the total platelet count? So platelet count is going to go down. So that's what causing the thrombocytopenia. Okay, why thrombocytopenia? Because of this thrombosis. So thrombosis leading to thrombocytopenia, that's what leading to thing. So then what about this microangiopathic hemolytic anemia, sir? The microangiopathic hemolytic anemia is because of, see, they are just like sharp hills, thrombi. Now when RBC are like, this flexible, this cute RBCs, when they are passing through these blood vessels, now there is a chance that this RBCs which are going with high velocity, they are going to strike to this thrombi. During this process, the RBCs are going to become damaged. Membrane damage can occur, or directly the RBCs can just go off. Okay, they can be ruptured and hemolysis can occur. So where is this hemolysis occurring? Within the blood vessel. So intravascular hemolysis. So these RBCs are going to hit to this platelet microthrombi, and the RBCs are going to break. Okay, RBCs are going to break. Now this break the RBCs. Okay, these RBCs which are having the breaks, these are called as helmet cells. Helmet cells are histocytes. Histocytes are helmet cells, the RBCs which are braked. So as the RBCs are getting break, that's why hemolytic anemia. So microangiopathic hemolytic anemia. There is problem in the microangios leading to hemolysis, leading to anemia. So one cause of MAHA, this microangiopathic hemolytic anemia, is Adam TS13 deficiency, that is leading to thrombotic thrombocytopenic purpura. Now second condition which can lead to microangiopathic hemolytic anemia is called as hemolytic uremic syndrome. Okay, hemolytic uremic syndrome. See, this will also lead to MAHA. Okay, microangiopathic hemolytic anemia. How? In the name itself, it's there. Hemolytic uremic syndrome. See, hemolysis is happening. That's why hemolytic anemia. Okay. What's the problem, sir? Here, the problem is the endothelial cells are getting damaged. Endothelial damage. So why endothelial cells are getting damaged? Because of a toxin. Okay, because of a toxin. The most important things I am telling you, sir, in hemolytic uremic syndrome, the patient is having an infection with what? E. coli O157H7. Okay, E. coli O157H7. See, with this bacteria, with this variant of E. coli, the patient is having an infection. So this E. coli is going to produce something called as E. coli verotoxin. Okay. Okay, E. coli verotoxin, which is also called as Shiga-like toxin. Not Shiga toxin, Shiga-like toxin. Okay, Shigotoxin is produced by the Shigella. Now this E. coli verotoxin is going to cause endothelial damage. Now once the endothelium is damaged, so within the blood vessel, look here, okay, endothelium is lined by, sorry, the blood vessels are lined by endothelial cells. Now once these endothelial cells, once they are getting damaged, what they will trigger? Damaged endothelium is going to release Von Willebrand factor. Von Willebrand factor activates platelets, platelet aggregation, platelet adhesion will happen. So now what happens here is, because of the endothelial damage, again continuously in the small capillaries, the endothelial cells are getting damaged. So on the damaged endothelium, what's happening? Platelet thrombi. Okay, platelet thrombi are forming everywhere in the smaller blood vessels. Platelet thrombi are forming. So this platelet thrombi, what they will do? They will cause damage to the blood vessels. Sorry, they will cause damage to the platelets. So platelets, sorry, not platelets, the platelet thrombi. Okay, these are the platelet thrombi, right? So what happened to the number of platelets? Platelets are going to go down. Okay, platelets in the blood are going down because all the platelets are involved in the formation of the thrombi. Okay, unnecessarily all the platelets are used up for the formation of the thrombi. So what happened to the platelets? Thrombocytopenia. Again thrombocytopenia. So what I am trying to put into your mind is, what are the different causes of thrombocytopenia? The different causes of thrombocytopenia are, one is immune thrombocytopenic purpura, second one is microangiopathic hemolytic anemia, which includes thrombotic thrombocytopenic purpura and hemolytic uremic syndrome because of E. coli verotoxin. Platelets are going to go down. Now here also same thing, when the RBCs are going to get hit to such platelet microthrombi, they are going to get lysed intravascular hemolysis. So that's why the name hemolytic anemia. Then what is this uremic syndrome, sir? Let me put it this way, sir. Hemolytic uremic syndrome is going to, these patients are going to have, yes, of course, thrombocytopenia is going to be there. So, okay, let me write here, thrombocytopenia. Okay, thrombocytopenia, sir. Okay, what about the bleeding time? Bleeding time increases. Bleeding time is going to increase. Now, what about the clotting time, sir? What about the clotting time? See, this is not a problem with the clotting factors. So, usually the clotting time is going to be normal. Sometimes even clotting time is elevated because here also some amount of clotting factors are going to be consumed. So, clotting time is normal or sometimes it is slightly elevated. Okay. Next, in hemolytic uremic syndrome, how to differentiate it? Okay, how to differentiate it with thrombotic thrombocytopenic purpura? See, in thrombotic thrombocytopenic purpura also platelets are going to go down. Okay, platelets are going to go down. Thrombocytopenia is there. How to differentiate is, see, uremia means kidney problem. Kidneys are damaged. So this platelet microthrombi are going to be especially involving the kidneys. Okay, so hemolytic uremic syndrome affects kidneys. Platelet microthrombi are going to form in the kidneys. So kidney damage, that will cause uremia because of kidney involvement. The kidney. In thrombotic thrombocytopenic purpura, important point which I want you to know is, it's going to mainly involve the CNS, central nervous system involvement. The platelet microthrombi are going to form within the vasculature of the central nervous system. So the patient is going to have neurological symptoms. Okay. Thrombotic thrombocytopenic purpura, neurological symptoms, and hemolytic uremic syndrome, the patient is going to have the uremic symptoms. Kidney related problems are going to be seen. So with this, the two things are completed. So the patient is going to have renal insufficiency, and their thrombotic thrombocytopenic purpura, the patient is going to have CNS abnormalities. Yeah. Now, after this, what we have to do is the qualitative problems. Quantitative problems are completed. Quantitative problems are completed where the bleeding time increases. Qualitative problems now. So quality means there is some problem in the quality. Which qualitative defect, sir? I have said you there is a receptor which is helping in the platelet adhesion. What is that? GP1B. And who is helping in platelet aggregation with one platelet with the other platelet? That is GP2B3A. So defect in, okay, here it's there, right? So defect in GP 1b. This is not there, sir, for example. Then what happens? Then platelet adhesion is going to be affected. Platelet adhesion is affected. So this syndrome is called as Bernard-Solier syndrome. Okay. Okay. So Bernard-Solier syndrome. So what exactly is this Bernard-Solier syndrome? In exam they will ask you, in Bernard-Solier syndrome, where is it like problem? Platelet adhesion, platelet aggregation, clotting problem, which problem? See, in Bernard-Solier syndrome, the GP1B is defective. So the platelets are not going to go and bind with the Von Willebrand factor. So platelet adhesion effect. Okay, platelet adhesion is going to be problem. Next, second thing is GP2B 3A. Okay, GB2B 3A defect. So the quality of the platelets is not good because this is not there. When it is not there, then platelet aggregation problem. Aggregation defect. So what is the name of this syndrome, sir? This is called as Glanzmann's thrombocytopenia. Okay. So Glanzmann's thrombocytopenia, it is due to defect in GP2B 3A where there is aggregation defects, aggregation defect. Okay. So these are the important things which I want you to know. The qualitative problems include two. Simple qualitative problems include two. One is Bernard-Solier syndrome. Second one, Glanzmann's thrombocytopenia. Okay. Apart from this, certain other conditions like uremia, for example, kidney failure, the patient is having kidney failure. Now the patient is having uremia. The platelet count is okay, sir. The platelets are absolutely all right. But in these uremic conditions, they disrupt. Okay. Platelet function. Okay, they disrupt the platelet function. So that is both adhesion and aggregation are going to be affected. Okay. So that's why in kidney failure, the patient is going to have bleeding. True, possible. Okay. Adhesion and aggregation are going to be defective in uremia condition. And for example, so if the patient is using aspirin, so what this aspirin is going to do? Aspirin will inhibit cyclooxygenase, you know it. Okay, aspirin inhibits cyclooxygenase. Now you tell me, sir, cyclooxygenase pathway is very much important for the production of prostaglandins, and prostaglandins will be converted into thromboxane A2, you know it. Okay, first if you use aspirin, cyclooxygenase is, once the cyclooxygenase is inhibited, what about the thromboxane A2 production? Thromboxane A2 is not there. Without thromboxane A2, do you think platelet aggregation is going to be like possible? So defect is like, no, it's not a defect. Okay, we are inhibiting. Okay, if you use aspirin, thromboxane A2 is not there. The thromboxane A2 production is inhibited. So platelet aggregation is not going to be happening. Okay, platelet aggregation is going to be not. Okay, so that's why in a patient who is at risk of, like, the coronary artery diseases, okay, if he is having atherosclerotic plaque, we know that atherosclerotic plaque will rupture at any time. It can form the thrombus and it is going to clog the blood vessel, leading to the myocardial infarction. That's why the patients who are, like, heart patients, they will be taking aspirin tablets. Why they will be taking aspirin tablets? Why? Because aspirin inhibits platelet aggregation. So when you take aspirin, platelet aggregation will not happen. Without platelet aggregation, no platelet plug, no thrombi. No thrombi means no clot. So the patient is not going to have myocardial infarction. Okay, no clotting of the coronary arteries, no myocardial infarction. Okay, so again, here what I am trying to put into your mind, platelet aggregation is not happening. Okay, platelet related problems. So now what we have completed is the quantitative problems and the qualitative problems are completed. Okay, Now, here, let me start with the, let me explain you some important points about the secondary hemostasis. Before discussing about the disorders, secondary hemostasis disorders, first let me tell you some things which you need to know. How many clotting factors are there? How many clotting factors are there? 12 clotting factors are there. Okay, sir. Out of these 12 clotting factors, factor number 2, 7, 9, 10. Factor number 2, 7, 9, 10. For their activation, for if you want to activate this factor number 2, 7, 9, 10, what do you require is vitamin K. Vitamin K. So, vitamin K, with the help of an enzyme, there is an enzyme, okay, vitamin K epoxide reductase, okay, with the help of this vitamin K okay, let me put it this way. So, these factors are inactive factors. 2, 7, 9, 10, 1, these are for example inactive. Okay. Now, you have to make them active. How, sir? Vitamin K with the help of enzyme called as vitamin K epoxide reductase. Okay. Sorry, I should actually put it this way. Yeah. Now, what is happening is vitamin K, not with the help of vitamin K epoxide reductase, sorry, it is gamma glutamyl carboxylase. Okay, gamma glutamyl carboxylase. With the help of this gamma glutamyl carboxylase, the inactive factors are getting activated. So, now they are activated 2, 7, 9 and 10. They are activated. During this process, say, during this process, vitamin K, it is getting, vitamin K, here it is in reduced form. Now, it is getting oxidized. Vitamin K, it is getting oxidized. Okay. So, what we have done? We have done gamma carboxylation. This process is called as gamma carboxylation of factor number 2, 7, 9, 10. What we have done is gamma carboxylation. If you do gamma carboxylation, yes, factor number 2, 7, 9, 10, now they are ready. They will be participating in the clotting, secondary hemostasis. For that, what do you require? Gamma glutamyl carboxylase and vitamin K. Okay. Now, question is, during this process, the vitamin K is getting oxidized. What we need to do is, we need to convert this vitamin K back to reduced form. We need to convert this to back to reduced form. Who will help that in this process? Vitamin K, epoxide reductase. Okay, see, vitamin K is going to be again reduced, reductase, reduced back. Okay, so vitamin K, epoxide reductase. Just now I have discussed about the aspirin, right? That's why I just want to discuss about one more drug which is called as warfarin. Okay, warfarin. See, this warfarin drug, what it is doing? If you take this warfarin drug, I hope you have already heard about this anticoagulants. Warfarin is an anticoagulant, anti-clotting. Yeah, anti-clotting or anticoagulant. So, if you take this warfarin drug, what it will do? It will inhibit this vitamin K epoxide reductase. Okay, vitamin K epoxide reductase is inhibited. When it is inhibited, now vitamin K is available in reduced form. No, there is no vitamin K. Without vitamin K, do you think gamma carboxylation of this factor number 2, 7, 9, 10 is going to be possible? No, not possible. So, now clotting will happen without these clotting factors 2, 7, 9, 10. Without these clotting factors, do you think clotting will happen? No clotting, no clotting, no clots within the blood vessels. Okay. So, warfarin is anti-clotting medication. It doesn't allow the clotting. Okay. So, what warfarin is going to do? Warfarin inhibits vitamin K epoxide reductase. Okay. Vitamin K synthesis or vitamin K reduction of reduced vitamin K is getting inhibited. Okay. So, this is what I want you to know. So, two things: aspirin inhibits cyclooxygenase, warfarin inhibits vitamin K epoxide reductase. Done, guys. Now, let's discuss about some. Okay, now let's discuss about some important disorders of secondary hemostasis. Simple disorders of secondary hemostasis. What are they? First disorder is called as hemophilia. Okay, see this secondary hemostasis disorders are clotting disorders, means defect in clotting. Okay, clotting. Again, if there is defect in clotting, there will be bleeding again, no proper clot is formed, so again it will cause bleeding, but here this is little bit more bleeding will occur, like bleeding into the internal organs, bleeding into the joints. Okay, more bleeding is going to occur. So hemophilia. Okay, hemophilia A. Hemo means blood, philia means loving, they love to bleed. Okay, so these people are always bleeding, hemophilia. So what exactly is this hemophilia A, sir? Hemophilia A, it is X-linked recessive disorder okay, it's X-linked recessive disorder where there is a deficiency of clotting factor number 8, clotting factor number 8 deficiency. So if clotting factor number 8 is not there, means which pathway is going to be affected? Intrinsic pathway. Intrinsic pathway affected. If intrinsic pathway is affected, now tell me what happens. Which time is going to be elevated? See, labs. Okay, what about the bleeding time? Okay, what about the bleeding time? Increased or not? See, bleeding time is always dependent on platelets. So bleeding time is normal. What about the PT and PTT? Sir, here the PTT is going to be elevated because PTT measures intrinsic pathway. 8 is involved in the intrinsic pathway. So PTT is elevated and PT is normal. Okay, there is no defect in the extrinsic pathway. Extrinsic pathway is occurring normally. Intrinsic pathway defect. Okay, and what you will see in the labs? Factor number 8 deficiency. Okay, so a normal platelet count is there, platelet count is normal, bleeding time is normal. Okay, so platelet count normal. Okay, so these are the important points which I want you to know. These patients are going to have deep tissue bleedings. Okay, deep internal bleedings will happen, like bleeding into the tissues, not just into the skin, bleeding into the joints. Okay, it's a bit more severe condition. Okay, post surgical bleeding, after the surgeries these people will have still bleeding. Okay, for example, usually how it happens is most of the time the patient doesn't know that he is having, for example, factor number 8 deficiency. Now this patient went for the surgery, so during the surgery there is continuous bleeding. Okay, post surgical bleedings during the surgery and after the surgery also bleeding, continuous bleeding, then we can know that okay, this patient is having factor number 8 deficiency. Okay, something like that. So what is the treatment? The treatment is just recombinant factor number 8. Okay, recombinant factor number 8. Next, hemophilia B. Okay, hemophilia B. So what is the deficiency in hemophilia B? Same, exactly same symptoms, same things will be seen, but here the deficiency of factor number 9. Factor number 9 deficiency. The factor number 9 is also involved in same intrinsic pathway. So if you look at the labs, so what about the bleeding time, sir? Bleeding time normal, PT time normal, platelet count normal, and PTT is elevated. Factor number 9 in the blood is going to be, what is the treatment? Simple, recombinant factor number 9. Okay, recombinant factor number 9. Okay, so hemophilia A completed, hemophilia B completed. Okay, A is 8, A is something like 8, right? A 8 deficiency, factor number, hemophilia B 9 deficiency. Now hemophilia B is also called as Christmas disease, just keep that point in mind. After this, let's discuss about Von Willebrand's disease. Okay, the third disease which I am going to discuss here is called as Von Willebrand's disease. So what is this Von Willebrand's disease? There is deficiency of Von Willebrand's factor. Deficiency of Von Willebrand's factor. Now you know Von Willebrand's factor is the one which is responsible for the platelet adhesion, platelet adhesion. Okay. So now if there is deficiency of Von Willebrand disease, how the labs are going to be? Okay, how the labs are going to be? Before that, let me tell you one thing. This Von Willebrand disease is the most common clotting disorder. Some students will have it out. Sir, why we are discussing this in clotting disorders? Okay, why haven't we discussed it in the platelet defects, like in the primary hemostasis? Why we are discussing it here? Because Von Willebrand factor is something involved in platelet adhesion, right? It's involved in the platelet adhesion, right? Okay, so what are seen in the labs is, so PT time, PTT time, and bleeding time. Okay, see, bleeding time is going to be elevated because the platelets are not coming and getting adhesion. See, Von Willebrand factor is less. So when Von Willebrand factor is not there, so platelet adhesion is going to be impaired. So automatically bleeding time increases. Next, PTT time is also going to be elevated. Now students will have it out. Why? PTT is a measure of intrinsic pathway. Now, due to deficiency of Von Willebrand factor, why PTT time is elevated? Is because, see, this Von Willebrand factor, it stabilizes factor number 8. Factor number 8. Okay, it stabilizes factor number 8. Okay. Now, if there is deficiency of Von Willebrand factor, this factor number 8 is also not going to be stabilized, or I can say it's not getting properly activated. So, when 8 is affected, intrinsic pathway is going to be affected. That's why the PTT time is elevated and the PT time is going to be normal. Okay, PT time is going to be normal. So, that's it. Okay, labs. So, what about the platelet count? Platelet count is normal. There is normal platelet count, but still the bleeding time is increasing. Why bleeding time is increasing? Because Von Willebrand factor is not there. So platelet plug is not properly getting formed. Okay. Next, what's the treatment done for the Von Willebrand's disease? See, Von Willebrand's disease, it's a, see, in the name itself is something like won, like winning something, won. Okay. So winning is something dominant, right? So it's autosomal dominant condition. Don't forget it. The autosomal dominant condition. The other two, like in hemophilias, they are autosomal recessive conditions. Treatment. What is the treatment, sir? It is desmopressin. So what is this desmopressin? See, desmopressin is V2 receptor agonist. It's a V2 receptor agonist. V2 receptors are the receptors of antidiuretic hormone. Okay, V2 receptors are the receptors of antidiuretic hormone. Now, why we are stimulating the V2 receptors is because you guys need to understand. See, these are the blood vessels. Okay, this is the blood vessel. Now, here I am showing you the endothelial cells. See, these are the endothelial cells. On the surface of endothelial cells, what do you have is V2 receptors. Okay, on the surface of endothelial cells, yes, V2 receptors are there in the nephrons. True, V2 receptors are there in the nephrons. Stimulation of the V2 receptors helps in the reabsorption of water in the collecting ducts. That's okay. But V2 receptors are also present on the endothelial cells. If you stimulate this V2 receptor with the help of a drug called as a desmopressin, now this endothelial cells, they will release more and more Von Willebrand factor. Okay, so these Weibel pellet bodies, these are the Weibel pellet bodies. Now they will be undergoing exocytosis and more Von Willebrand factor is now available. Okay, so the treatment of Von Willebrand disease, there is less Von Willebrand factor. What you need to do? You need to increase the Von Willebrand factor. So what you have to do? Stimulate the V2 receptors. Stimulate the V2 receptors with a drug called as desmopressin. Okay, desmopressin. Okay, so with this we have completed the three things: hemophilia A, hemophilia B, and hemophilia A, B, and Von Willebrand disease. Now the last thing which I want you to know is vitamin K deficiency. Vitamin K deficiency. You already know it, vitamin K deficiency. Who will get vitamin K deficiency, sir? Usually, vitamin K deficiency is going to be seen in newborn. See, in us, the gut flora, see, how will get vitamin K? Vitamin K, you will get it from plants, leafy vegetables, okay, you can get most of the vitamin K is getting synthesized by the gut flora. Okay, the gut microbiota is going to produce the vitamin K. In newborn, the gut flora are not properly developed. There is no proper gut flora is there. So the newborn can have vitamin K deficiency. Okay, initially. So in the newborn, what we have to give? We have to give injections. Injection of vitamin K. Okay, we have to give vitamin K injections. Okay, usually throughout the India, we'll give vitamin K injections. Okay, immediately to the newborn, we'll give which vitamin? Vitamin K. Who else can get vitamin K deficient? Okay, so antibiotic therapy. Okay, long course of antibiotic. Okay, inadvertent usage of the antibiotics will kill gut bacteria. So vitamin K deficiency can occur. Okay. Next, in certain diseases, okay, in certain diseases like malabsorptions. Okay, you are taking vitamin K, but you need to remember that A, D, E, K. A, D, E, K are fat soluble vitamins. Okay, A, D, E, K are fat soluble vitamins. Now, for example, you are having malabsorption because of pancreatitis, okay, because of pancreatitis or because of um, celiac disease, okay, celiac disease, Crohn's disease, all these are malabsorption conditions. Okay, celiac disease, Crohn's disease, pancreatitis. So in pancreatitis, pancreas is not producing the enzymes. Okay, it's not releasing the pancreatic enzymes. See, for example, I'm an alcoholic man. Okay, so alcoholics are going to have the chronic pancreatitis. Okay, acute. See, alcoholics will have acute pancreatitis. So repeated episodes of acute pancreatitis can lead to chronic pancreatitis. So in chronic pancreatitis, the entire pancreas is going to worn out. Okay, it's no longer going to release the enzymes, as it's not releasing any pancreatic enzymes like pancreatic lipase, colipase. These lipases are not getting released, so no fat digestion. Without fats, ADK is not going to be absorbed. So in multiple conditions, like for example pancreatic insufficiency, okay, pancreatic insufficiency or Crohn's, celiac disease, these are the conditions where there is malabsorption. So you can get vitamin K malabsorption. Okay, vitamin K deficiency can be seen. So you know it, when vitamin K is deficient, factor number 2, 7, 9, 10, they are not gamma carboxylated. When they are not gamma carboxylated, they are not going to be activated. So 2 is involved in which pathway? Common pathway affected. 7 is involved in extrinsic pathway, PT time elevated. 9 is involved in intrinsic pathway, PTT time elevated. 10 is involved in common pathway. So all pathways are affected. So the patient is going to have coagulation defect, clotting defect. So he is going to have bleeding. These patients are going to have bleeding. So what we have to do is we have to like give the clotting factors. Sorry, we have to give vitamin K. Okay, vitamin K should be supplemented to these persons. Okay, with this we have discussed the important types of the important examples for disorders of primary hemostasis and secondary hemostasis. I hope the class is helpful. See you tomorrow with the new topic. Okay, okay guys, good night. See you tomorrow. Thank you.